I see. I just got your email that it has been extended. So.
Yeah, I just got it.
So we are going to work with at least 1,800 kids.
Okay.
And you can say with their families. I lost my parents at age 11, so I was raised by the community and extended family system. So for me, it was always being able to give back to the community that raised me, having grown up as an orphan child, and also to young people that I thought were going through situations like I went through. That was and still is the driving force behind the work I do. You never get to know who is working.
Oh yeah, no, there's so many things. Yeah.
So when you sent me that email.
I didn't meet Fred in Rakai, although he works in Rakai. I didn't meet Fred in Uganda, even though he works in Uganda and is there a lot, and I am. I met Fred in New York because colleagues at the School of Social Work introduced us. In fact, when I later went to Uganda with Fred, I realized that his office was down the street from my office in rural Rakai.
I'd heard about his name and he had heard about my name, but we had never exchanged, notes to see, where is your research in regards to this and where is this?
I worked for 20 years in the U.S., both in local public health in Baltimore, and then I worked for CDC, so a lot of my research has always been on adolescent health in the United States, teen pregnancy, teen STDs, HIV, and those kinds of issues. I was lucky to meet one of the people at Columbia that helped initiate the Rakai project, Maria Waver. Maria invited me to that opening, literally, of the new building down in Rakai. And I was pretty wowed by the science, by the people, by the country. So she encouraged me to write a grant that would look at very specifically why young people 15 to 24 are still at risk for HIV. We are very worried that the latest survey data suggests some resurgence of the epidemic. It's risen among middle-aged adults, but it's also risen among young people, teens and young adults, those 15 to 24.
What is disheartening is people, the English word is becoming complacent or something like that, and we shouldn't be complacent and think that this is the disease of the past. We cannot let our guards down at this particular time. These young people need to know that AIDS is real, it's still there, it's still a problem, and that there is no cure. The best cure is really to be very responsible.
We've also done a whole series of what we're calling qualitative research studies, trying to understand the epidemic from an adolescent point of view. What are the developmental issues? So how does, say, the act of leaving school in a country where education is highly valued, but many kids don't have access to education, how does that, put a young person on a trajectory towards HIV or away from HIV? What we hear in our research is kids drop out of school because they can't afford to pay for school uniforms, the school fees, which are not real expensive, but if your family has no money or if your parents died and you have no money, you can't go to school.
When you are not in school, the risk of you getting engaged in risk-taking behavior, it's higher.
So staying in school has a very strong protective effect.
Uganda instituted universal primary education about 10 years ago. And what they have found that most children, they enroll but they are not completing primary school.
Social institutions are enormously powerful in either supporting or failing young people. And I think Fred probably understands much more, because he's a social worker, about the importance of social context, the importance of family, the importance of education. He has a profound understanding of how social forces affect personal behaviors, for instance.
What is it that will make that child stay in school if they don't have hope that the future will be better? What is it? What is it that will keep that parent from pulling that child out of school and marrying them off? So if you connect these young people and their poor families to financial institutions, and you get them the financial management training they need, and you get them the mentorship they need, and you seed their accounts, and you tell them, we'll work with you if the child is in school, they will do just well. This has to be implemented as a bundle of activities, not as an isolated thing. But the question was, can we test this on a wider scale? So we got 10 schools. We randomly assigned some to the treatment condition. And then the other group, they received everything that the treatment condition receives, but not the savings account and economic empowerment. And we saw that, wow, the treatment group did better than the control schools. And then the question was, is there something about these accounts that is making us realize these impacts around health? We are trying to really now see if this is going to be implemented as a policy, how should it be designed, and what is the cost, what are the long-term impacts, and what are the health outcomes really, and educational outcomes and other outcomes.
The social conditions that put people at risk, put adolescents at risk here and in sub-Saharan Africa, a lot of them look the same. Obviously the context is pretty different. Uganda is much poorer. It's primarily a rural country. A lot of people involved in subsistence agriculture. So the social context can be very different, but the adolescent developmental issues, the aspirations to be better in life, the desire to become a doctor, a nurse, or a teacher, remarkably, those kind of issues cross-cut. His interventions make a lot of good sense. His program supports young people to stay in school by paying those school fees. But he also gives kids, what should we say, motivation, hope. I think what we're going to see is that that system of care, that system of education is going to say, oh, well, we're doing it the way Fred does it, because that's the right way to do it.
Our work definitely arguments the other. Then we figured that, you know, there's something here to share.
We are trying to join forces, and we're going to try to look at the long-term impact of that kind of opportunity, that kind of intervention. We see the short-term impacts in terms of lowered risk behaviors, in terms of staying in school, but you know, what are those kids going to look like when they're 22, 25? You know, are we making a change in their life? We believe we will, but we need to document those more long-term effects, and so that's part of our work as well. So this will be a little different, but we have a lot written.
Oh, no, we do. I agree, and it's a 10-page proposal. You know.
Collaboration between health professionals and social scientists or social workers or other folks is what public health is all about.
It's a great combination of skills and knowledge, medical doctor and the social scientist.
Yeah, it is pretty exciting. I'm glad I met Fred.